What we're going to talk about is GI drugs, and we're going to talk about sort of the long-term safety of some of these drugs. I feel like some of these have been around, and then there's like something new that comes up in the literature. I'm like, wow, that's interesting. I do spend a lot of time updating my slides. So if there's nothing new, it means I've looked and there's nothing new. I really try. And sometimes I miss things. Every once in a while, I get these conferences, someone goes, have you heard about? I'm like, oh, I must have missed it. But I do try to update every year and find new stuff and rearrange things. So, but I don't think what we're seeing in pediatrics changes, right? The basic thing is we still see colic. We still see gastroenteritis. We still see lots of constipation. There's new guidelines for constipation, by the way. GERD, dyspepsia, and functional abdominal pain. So what we're seeing hasn't changed, so some of our treatments haven't changed. Colic. Colic is colic. I love this. It was featured on NPR and in USA Today. There was a big study that came out early in 14, a little over a year ago, about using probiotics in children for colic. So basically, we know 10 to 20% of visits in the first 4 months. This is a huge stressful thing for parents. And so they did a study where they started these kids on probiotics at 1 week of age. How do you know at 1 week whether they're going to have colic or not, right? You know, it's just like, okay, you know, maybe a parent said they had the other kid had colic, so they're like going, I don't want to do that again. I'll sign up. You know, I don't know. So what they found in this original study by Indirio was they had less crying, less regurgitation, and more frequent stools. And so that's exciting. So last year I said Gerber Soothe. Someone just told me that Walgreens has their blend that comes with vitamin D for these breastfed babies. So, you know, you got this great thing that we can now give to people for colic. But then there's some other studies that were done. And, you know, it's like anything. Australians, at the same time, published just after this other one. They're like 2 studies in 2 continents, both studying the same thing. They did a randomized, double-blind, placebo-controlled, looking at a probiotic. And what they found is the group on probiotics cried more. So, is it the strain of probiotics? Who knows? I mean, you know, it was only 167 kids. So there was a systematic review published in 2013. That's very consistent with this. Half of the studies show they get better. Half of the studies show they didn't. So, you know, like probiotics won't hurt them, and they have a 50% chance of working. I guess that's what the final is. I mean, you know, what can you say? You know, or like last year I was thinking, I've got the cure, and it's pretty benign, and if it works, boy, what a great thing, right? And so, you know, hopefully it does work most of the time. But if the kids cry more, maybe those are the ones that are going to cry more. Who knows? Gastroenteritis hasn't really changed, except for using probiotics. There's a number of studies to say to do that. We all know to use oral rehydration solution. One of the things that, and if you haven't heard my talk before, if you've heard this before, I apologize. One study, which I just think is the most creative thing, is they gave the parents, while they were waiting in the ED waiting room, a syringe and some oral rehydration solution, and said give them 5 mils every 5 minutes while you're waiting, because we can't see you for an hour anyway, right? So by the time you see them, guess what? You've already figured out whether they're going to tolerate oral fluids. And because they're sitting out there in the waiting room, they can't, like, you know how they do? They give the bottle and they let them drink 4 ounces and then they puke, right? You know, you can't, if you tell them to give them the syringe and they're out there with the syringe, they can't really go that fast, right, with a syringe. And so they found that they had fewer admissions, fewer patients needed IV fluids. And because the parents had already figured out that they could do that by the time you see them in the waiting room or the exam room, that they were doing that. So, I mean, that's something to think about. I just, when I see these kids, I just have them take up an exam room for an hour, and I go in between every other patient and go, how are you doing? You got another 5 in there? Let's go. Come on, they haven't vomited, great. And so they just don't believe that they're going to keep it down because they keep doing the give them too much, right? This is nursing 101 from the whole 20 years I've been a PNP. So how come parents can't figure this out, right? Why are we giving IV fluids to these kids when they don't really need it? And for the whole 20 years I've been a PNP, which is actually 21 years this year, we've really said that we're only supposed to be using IV fluids for moderately to severely dehydrated kids. Don't give them any antimotility meds. I'm always surprised when parents go, oh yeah, we gave them some diarrhea medicine, it didn't work. Don't do that. What does work is probiotics. We do know that probiotics do work. So all the kids with gastroenteritis, you should be recommending probiotics. It does shorten the course of diarrhea by about 24 hours. There's multiple studies and reviews that say that. And also antibiotics, associated diarrhea response to probiotics, also by shortening that. So now we pretty much, everybody that has diarrhea for any reason, we stock it in our pharmacy. We just give them probiotics. Or I tell them to go buy some if they want. We don't have the powder kind. We have the capsules you have to open. Those are kind of spendy. Anti-emetics. So one of the issues is that Zofran, Ondansetron, is not approved for gastroenteritis in kids. But it's used all the time. How many are using this off-label? Yeah, no. It's approved only in kids for oncology and postoperative vomiting, but who's going to go do the study when we're already using it all the time, right? And this is one of those ones where the best pharmaceuticals for children act people go, well, it's not labeled for that. And we're like, well, go out into regular practice and see what people are doing because they're out there prescribing it all the time. I've done it. I mean, what can you say? You give it to them, hour later, they're going home on orals, and so, yes.
Well, I work at an emergency room. We do it all.
Yeah, it's the other vitamin Z at the emergency room. Zofran and Zithromax, they come out of the ER. Yeah, I know, you don't have to use it. No, I agree. I agree with you. I agree with you 100%. It works really well, okay? And it is appropriate to use it. It's just not labeled that way. So if your Nurse Practice Act that you're prescribing under says that you have to prescribe only on-label medications, that's a problem for you, okay? It's not a problem for me because I can prescribe off-label if I want where I live because we have totally independent practice. So just think about it. I'm not saying not to do it. I'm just saying it's not labeled that way. They've looked at oral dimenhydramine. That's the car sick medicine. Doesn't work for gastroenteritis. It works for car sickness, but doesn't work for gastroenteritis. So it's widely used. We know it. There's a brand new study just in 2015. Really improve the outcomes of patients. They get better. They stay hydrated. They don't have to be hospitalized as much. And clearly it works. Clearly it shortens. It's not going to shorten the course because it's viral. It has to run its course. But the likelihood of them being hospitalized decreases. The concern is people are using it for everything. I mean, sometimes I think they just put it under their tongue when they get to the ER for whatever. They're talking about they're giving it for pharyngitis. Yeah, the kids puke with that. Head injuries, abdominal pain, So, I have used it for migraine kids that are having intractable migraine and vomiting. I have used that in urgent care before because you can't get anything down them. So you got to get something down them. And anyway, the bottom line is it's off-label, but people use it. The only thing you really have to worry about is IV high dose does cause prolonged QT. So if you're just using the 4 to 8 milligram sublingual, it's probably safe. And I did my off-label talk. Now, it's fine. I use it. Why not? Okay. It works. And so I wish someone would go to the study so it's not off-label anymore, right? That's what the main thing is. Okay, constipation. Brand new guidelines just came out. And one good thing is the old guidelines didn't have Miralax, right? The new guidelines do, so that's good. So we know up to 1/3 of children through age 12 have an episode of constipation. Is 3% of our pediatric visits in general pediatrics, 25% of our visits to Peds GI is constipation. So you want to make money? Go work in Peds GI. You know, everybody's constipated. They're going to come to you. Sometimes I feel like every kid I see is constipated. But, you know, it just happens. There is the new guidelines. This was a combined guideline from both the American and the European pediatric GI folks. They got together and they have one big guideline for everybody. The old guidelines talked about parental education. These new guidelines don't, but I think we need to remember what normal bowel movements are because parents don't know, and how often they should be having, and what is constipation. So constipation is a delay or difficulty with defecation that is present for greater than 2 weeks. We need to teach parents about what normal bowel movements are in infants. They're not constipated if they don't go for 5 days and they're breastfed, right? As long as when they poop, it's nice and soft and they're fine. So we need to talk about like what is normal, what's not normal, what is real constipation. And I think PNPs, we're really good at that. I think we're really good at talking about what's normal. And hopefully we're not overprescribing medicines for just normal occasional stools. Functional constipation. These are the new guidelines. Tabors is the lead author on that. That's why it says Tabors. So they have really come out with some not to do's, all right? So they recommend that you don't have to do a digital rectal exam anymore. So I don't know about you, but I bet some kids are really happy about that. Doesn't make a difference. Evidence doesn't support it makes a difference. So you don't have to do that. You don't have to do an abdominal x-ray anymore, okay? So that is another thing that evidence doesn't support. Colonic transit studies, which I had never heard of before. I had to figure out, what is that? It's actually where they put a little thing in and study how long it takes things to go through the colon, or rectal ultrasounds, which I don't know about you, I've never ordered a rectal ultrasound in a kid. All of those, they say don't do them and don't make a difference, okay? So that's good. We're going to do less intervention for their constipation according to the new guidelines. Fiber. Get this one. So here we are. Fiber. Evidence does not support the use of fiber supplements in the treatment of functional constipation. Evidence does not support the use of extra fluid in the treatment of functional constipation. I put it in quotes because I think people wouldn't believe me. So, so we're talking they're already constipated, right? They're already constipated. It's too late to use fluid and fibers. Fluid and fiber is before they get constipated and to prevent further constipation, but not once they're constipated. Probiotics. Evidence does not support the use of pre or probiotics in the treatment of childhood constipation. Behavioral therapy or biofeedback. Those are your stool holders. That doesn't work either. So there we are. All the things that you're not supposed to be doing or that they don't support doing. Once they're constipated. So functional constipation means they're already constipated. What they do say is, guess what? We can use Miralax. They finally decided it's okay. It's now on the guidelines, and they basically say it's the only thing that works really well. I think we figured that out already, right? Like 5 years ago. How many of you guys figured out 5 years ago Miralax is Miralax, and that's what you use, right? Because it tastes good. No, it doesn't have any taste at all. And so, but the problem is that there have been no placebo-controlled studies on the use of laxatives or enemas on disimpacting kids. But what they recommend is you can use PEG, which is Miralax, polyethylene glycol, with or without electrolytes. You give them 1 to 1.5 grams per kilogram per day for 3 to 6 days. I think that is probably what's new, is the 3 to 6 days. It used to be kind of shorter. People did really high dose, almost like the bowel clean out you do if you're going to go have a colonoscopy. And so what they're saying is do it a little bit lower dose for a little bit longer time. Okay, 3 to 6 days, they should clean it out. You can do an enema, but if you're doing enemas, once per day for 3 to 6 days. is what is recommended for impaction, okay? And they will only recommend that if you don't have any polyethylene glycol. So I don't know about you, but you can go down to every store practically and buy that stuff. So I don't know where you would be that would not be available. And if you ask a kid what they would prefer, they would not. They will say, Mom, let's go find the other stuff, okay? So they don't want enemas for 3 to 6 days. So really what they're saying is use the polyethylene glycol. I saw a hand up.
This is just rhetorical, but if you can't do a digital exam, you have to do it KUD. How do you know there's fecal infection?
Well, that's just it. That's what their guidelines say. Well, they probably haven't pooped for a while, or you have the stool that stool leakage that happens with encopresis. That's pretty diagnostic. Yeah, I know. The guidelines say like, oh yeah, because there is something about showing somebody an X-ray and they got this ball of poop that's like this big, it looks like, and you're like, that has got to come out. Right? So yeah, but that's what the recommendation is. And the one thing that a digital exam is going to give you is if they don't have impaction, you're not going to feel, if they've got a big hard ball of stool, you've got a different problem than someone that doesn't. But they don't, that's what they say, you don't have to do it. I guess what they say is you don't have to do it. There's no evidence for doing it. That doesn't mean, they don't say don't do it. Okay? So what the goal says is, so once you get them clean out, so this was the clean out, right? We're going to do it 3 to 6 days. Then we need to put them on maintenance, all right? And that they show that polyethylene glycol is more effective compared to lactulose, milk of magnesia, mineral oil, or placebo. And the maintenance dose is 0.2 to 0.8 grams per kilogram per day. And if you can't get polyethylene glycol, you give them lactulose. There is dosing for mineral oil in there if you want to give mineral oil, because it's a lot cheaper, by the way. Man, you can get a whole bottle for like $1.20. That's what I use for my cats, you know, for hairballs. And but like if you are in a real, I mean, Miralax is expensive, even the generic. I mean, and think about it. If these people, if their kids are on this chronically, that's a lot of stuff. That's money all the time. So you can use other things that are less expensive. They don't say not to use them. They just say it's more effective to use the others. So if you want to use mineral oil, as long as they're over a year of age, it's 1 to 3 mils per kilogram per day. Max is 15. You can do milk mag, same thing, 1 to 3 mils per kilogram per day, up to 15 mils. So you can use that. That's all in the guidelines. The guidelines, you can download them for free if you want to. How long do you treat them for? Well, they say at least 2 months, okay? And they should be symptom-free for at least a month before you discontinue treatment, and you should wean them off. So you don't have them stop it, you wean them off. So you go to like every other day, every third day. So you go slow on weaning them and making sure that at the same time they're doing fluids and fiber. That wasn't in the guideline, but I think they still need, these kids aren't drinking, and you know their diets don't have enough fiber in them, so it's not going to hurt them. But they also say that if they're in the middle of toilet training is not the time to stop their medicine. So you wait till they're done toilet training, and then and some of this is so logical. You're like, clearly they didn't have a P&P on the committee, because the P&P go like, of course you wouldn't stop it in the middle of toilet training, but they have to write it, so it's there. Okay, so don't stop it in the middle of toilet training. So this is good. So we have some nice guidelines that now say we can do what we've been doing, all right? And just do get these kids off. They're not on it forever. Functional constipation, you want to figure out if they're impacted or not. So like you say, how do you do that if you can't do a rectal and they can't do an x-ray? Like, okay, I got the x-ray visions out. Let's figure this one out. Treat the impaction. The follow-up is really hard. I don't know about you guys, but they do it for a little while and then they stop and then they're back 2 months later and they're all plugged up again. And, they really need to treat for 2 months and then, try to wean them, go slow, and hopefully then they don't get constipated again. Bowel program is important. So what is their prognosis? So 80% of the kids adequately treated are not using laxative at the 6 months follow-up. So if you do it right, they should be able to do okay. But remember, we got 20 of them that aren't. Okay, 20% aren't. But if we delay the treatments, we don't get them cleaned out and onto maintenance, really, so, go ahead. Miralax isn't going to hurt them that much. We're going to talk about that in just a minute. But, go ahead and get them on that, because if we delay treatment, they actually have a worse prognosis. So if you think they're constipated, go ahead and treat them. So this, of course, now that we're giving it to everybody, there is now two things that have come out. There's been a meta-analysis by Chen in 2014 that said it's safe. The meta-analysis all says safe, effective, better acceptance by children, very consistent with the guidelines. But there is a very concerning report that came out that the FDA is watching, is that there seem to be some neuropsychiatric ADRs, and it's been over the last 3 or 4 years, they're having these sporadic reports. And so the concern is it just random, right? And so the kids are just randomly, they're on the medicine and they're having this neuropsychiatric behavioral stuff, or is there a correlation? We don't know. But I do, I think that only give it if we need to, and they are funding a study of kids that are already on it to see if there's any sort of correlation. So if you get a parent that said, well, I heard that kids get crazy on this stuff, there's no evidence. Okay, there's been a few reports. They're trying to figure it out. It's probably not going to be supported. But, we think millions and millions of kids are on this, right? Who is not using this stuff, right? So we're all using it. If it really was a real, true neuropsychiatric, it would have shown up big time in the fact that we're all using it. So, but, just to know that's kind of out there. Anyway. Infants less than 1 year, we don't give them Miralax necessarily. These kids, are they breastfed? We want to make sure they don't have megacolon or Hirschsprungs or something like that. Are they gaining weight well? Kind of look at all the other causes. Don't just start with a laxative with them. If they're less than 12 months, the new guidelines do not address less than 12-month-olds. Okay? The old guidelines really clear. They had a whole section on less than 12-month-olds. So we're sort of still stuck with the old guidelines about that because they literally hardly talked about them at all. So they still, I would still recommend the prune juice, and you can use lactulose or sorbitol. You can use corn syrup. If you need to give a glycerin suppository, you can. So I would stick to some of those old ones that have been around since my mother was a kid. Corn syrup, it probably won't hurt them. There was some early concerns about botulism in corn syrup, and those really haven't proven true. It's really only honey that we've had to worry about. Dark corn syrup is the one that has been used for hundreds of years for constipation. No study says dark works better than white. They're pretty much the same. They have they're a hyperosmotic. They pull fluid into the gut and they loosen the stool, and that's what happens. Okay, so that's what all these do. Okay. The fiber recommendation on preventing constipation. There's not good thing. The guidelines say not to use it if they are constipated. They don't really say what to do to prevent constipation. But they find that there's been a study recently about using Miralax or laxatives with recurrent abdominal pain. Probably those kids are constipated, so it doesn't hurt if they come in with stomach aches and you've worked out everything else, try some Miralax. When we look at overall kids showing up in the ER for abdominal pain, most of the time they're constipated. More than, especially adolescent females even, more than GYN problems for abdominal pain, more than appendicitis, they're constipated. So we gotta, get these kids to have better bowel habits. I think it starts when they're like babies, and get these parents when they start. We need to really, as part of the bike helmets and the, car seats, we need to talk about, bowel habits, because otherwise we're getting all these kids that, they're not developing good bowel habits, and they're really, I don't think we should be using as much medicines as we are. And there's nothing else new in the literature besides the new guidelines. Okay, GERD. We all know what GERD is. Basically, we've got kids that are spitting up. Or true GERD, so we have the happy spitter, which is the GER without the D. Or we have the grumpy, fussy baby with GERD. And just a reminder that happy, healthy infants cry 2 hours a day. Happy, healthy infants, not with colic, cry 2 hours a day. So first, we have to teach people the baseline normal. It's normal for kids to cry. Up to 2 hours a day is pretty normal. And so that is not a kid with GERD. True GERD, they're not gaining weight. They have esophagitis. They have respiratory disorders. This one is a tough one. These are old guidelines. No, they, oh no, so these are, sorry, I didn't change my date. These are the 2009 guidelines. The happy spitter, these kids with recurrent vomiting, my oldest son was the worst, man. He puked all the time. I had to carry extra clothes for myself because he just was like, "Plah," you know? He'd eat, he was breastfed, you know? He's like, he'd eat, "Plah," you know? And what can you say? He just was like that. He's still a happy eater. So the thing is, you can try them on thickened formula. You can try them on the sensitive formula. It's the sphincter at the top of the stomach is just not tight. It's not holding things in, and they're just overfeeding. We do have people that are overfeeding kids, though. I mean, I really think people do not know what a normal kid's supposed to eat. When they come in and a 2-month-old and they have an 8-ounce bottle, I'm like, come on, folks, you know, your baby shouldn't be eating that much. No wonder they're spitting up. You know, what has happened to the perception of feeding that people are overfeeding their kids to this extent? They're giving them way too much. No wonder they're spitting up. So you can try them on hypoallergenic formula. That stuff's really expensive, you know, so it's a lot cheaper to just feed them less and try that first. And if they don't get better, they shouldn't be spitting up once they're 18 months old. If they're still doing that, then they probably need to go see Pete's GI because there's something else going on. Infants with GERD. These ones is been around. And so the interesting thing is, I was on the Best Pharmaceuticals for Children Act Committee. We talked about this. I was advocating, we need to do studies on all of these proton pump inhibitors and stuff on kids because all these people are out there prescribing it. And they go, well, they're not supposed to be. The guidelines say they're not supposed to be. So what you're supposed to be doing with kids that are truly the irritable kids, vomiting, not gaining weight, they have more than 2 hours a day of irritability, is to do a trial of hypoallergenic formula first. And if they're not getting better, you're supposed to refer them to Pete's GI for pH monitoring. Okay, that's what the guidelines say. How many of you can get kids into Pete's GI in within 3 or 4 months? It's so hard to get kids in. There's just it takes forever. I mean, the kid is going to outgrow it before they get in. So, yes. Pardon?
You wouldn't want to switch.
No, breastfed kids are different. That's when you start working with moms and with their diet. So these are the breastfed kids. Okay. So with the breastfed moms, sometimes they do some diet changes, reducing the mom's intake of dairy and trying different things. It's really tricky because there's no clear thing that you can eliminate from mom's diet that will say always it makes it better, you know? So this is a tough one. Older kids, clearly they can tell you they have heartburn. You can put them on a proton pump inhibitor. You want to put them only on for 8 to 12 weeks. I have been so surprised when I see kids, and somebody a year ago put them on Prilosec, and they're still on it. That's not the way it's supposed to be done. They're supposed to come off. Even the adult guidelines say you're supposed to come off after a couple months, okay? So these were never intended for long-term therapy in healthy kids. It's a little different if we got these neurobehavioral kids that have chronic reflux, but normal healthy kids shouldn't be on proton pump inhibitors all the time. And if they still persist, refer them to Pete's GI. So here are Greg Kearns. I like him. He's really great. He's out in Kansas. He was sitting at the table when I said, we need to study proton pump inhibitors in kids. So, because it's really, really serious that we don't know what these do long term. So really what you get is an irreversible reduction in the proton pump inhibitor. So you reduce the acid by over 90%, and they've always said to only use them for severe GERD. Every single study they do, multiple randomized controlled trials, says there's no difference between proton pump inhibitors and placebo in the treatment of GERD in infants. Okay? So these guys did another one. They looked at the whole thing. What they recommend is if you must use it, you must use it in the slowest effective dose, only once a day, and get them off of it fairly quickly, and don't use twice a day in kids. So it has been studied recently. There's been it's frustrating, I know it's frustrating to have these parents that are saying their kids are spitting up, but spitting up is not GERD. And anyway, there is a couple long-term studies. Once again, they keep saying there's no evidence for use in children. The big concern is we're suppressing acid production at a time when these kids need to be absorbing nutrients that require acid. Okay? And we know in adult studies that we do see some significant long-term problems, especially in the elderly, that have lower acid production. So kids have lower acid, infants have lower acid production too in their stomach, and now we're decreasing it more. So in adults, we are seeing some vitamin B12 deficiencies. There are some early studies that look at that's possible gastric carcinoid tumors. They haven't really found that out, but that you'll still see that in the literature. Decreased calcium absorption, which totally makes sense because you need acid to absorb calcium. In elderly people who are immobile, they have increased hip and spine fractures. And but not people that are mobile. So what does that mean? Is it a problem or not? They recommend stepping people off of therapy after 2 months, okay? Always. There was a study that was done that looked at 113 kids who were neurologically impaired, and they followed them for 35.2 months, so about 3 years. And they said that the vitamin B12 level stayed in the normal range for these kids, most of them, and that, they seemed to do okay. But those kids were already neurologically impaired. So, we don't have any good long-term studies in kids. And that is really what needs to happen, is we need to really follow these kids long-term. Yes?
I noticed that in your slide you talked about thickening formulas.
Yeah,
There's a lot of discussion now on particularly the smaller kids, the preemies, with the thickening formulas, and not use that because of their increased risk for any safety.
well, and the preemies, yeah, well, those kids, you should be those are kids that are in the NICU still. I wouldn't, yeah. Really? Because I hadn't seen that. The not adding rice to it, but the ones that are the engineered rice thickened ones. Yeah. Oh, I haven't seen that evidence. If you could email that to me, I'd appreciate it, because that would because I didn't see that. So anyway, long-term use, we don't have good long-term studies. Basically, multiple studies have said we overprescribe. That when you actually go in and do the pH studies, that these kids don't have GERD. They probably have just GER without the D. They're just spitters. Or they got something else go along. There's no improvement in symptoms, and 99% of the time, they're not being prescribed according to the guidelines. So, I would hope that you will think about this. I know there's a lot of pressure from parents. Parents don't want this. They want a magic pill. We have to talk to them about this. There's not any evidence that says these work. Yes?
Is the Anti-emetics off the table now, or only
No, none of the acid suppressors. No proton pump inhibitors. No, yeah, that's what the guidelines have said for almost 10 years. And they're not going to go study it because they say the guidelines say not to do this. So what they're saying is, if you really think you need them, they need a pH study to see what you're treating. What are you treating? Okay, it's just like the antibiotics. What are you treating? Are you really treating pathology, or are you treating the parent's symptoms? So we really need to think about this, because all the studies say that when you actually do pH studies, they don't really have GERD, okay?
But if you do get a positive pH study, are you saying you just bypass H2 blockers?
Yes. So positive, yes. I think what they're saying now is if you get a positive study, you can just do the proton pump inhibitors. They are approved for young kids, okay? And they don't have as much rebound with that one. So you could use either one, right? But, I think they're using proton pump inhibitors mostly if you have a pH study that's positive. So if you do it and it's positive, yes. That is really appropriately diagnosing. Yes?
Question about corn syrup in formulas and giving corn syrup for constipation. Corn syrup has been named as part of our obesity problem.
Right.
That starved infancy with corn syrup?
Well, we're talking about corn syrup in everything. Corn syrup is in all the sodas and everything. That's a manufacturer has put it in there as a cheap way to make things sweet. I don't think putting corn syrup for some constipation, it's not daily corn syrup. We're talking about they're constipated, get some corn syrup. When they poop, then we don't give it anymore. We're not saying put it in every day as a preventative thing. So I don't think that's contributing to the problem. There is a lot of corn syrup in a lot of products, but not the Carol corn syrup for constipation. I don't think that's contributing to it. Kids already like sweets. Okay, so here we go. The Centers for Medicare and Medicaid is also following this issue of overprescribing proton pump inhibitors for children. They published a document a little over a year ago that said don't prescribe them to children. They're overprescribed, not indicated in infants. Do them short-term for GERD or esophageal erosive esophagitis, and also to be concerned about the fact that when you give a kid a proton pump inhibitor, the acid also keeps C. difficile under control, and so people on proton pump inhibitors are increased risk for C. diff. Okay, so pay attention. And this document also says to monitor for low magnesium levels. Okay, so really what the CMS is saying is we got all these kids on Medicaid and they're being inappropriately prescribed to. Let's give people some guidelines about what is appropriate prescribing, and they seem to be systematically doing this. So I don't know what the next step is. Are they going to start coming after people for overprescribing? I don't know, but that's a really, so like, is it going to become a no-pay event? It's kind of weird that the CMS people are publishing these, but I think it's good because it's really saying they're serious about this. We are overprescribing another type of drug. So really their goal is to improve the quality of care and enhance patient safety by educating providers on the proper prescribing of PPIs to pediatric patients. That's what they say the goal of this is. And so you can find this at the CMS website. We all see kids on Medicaid. So, they're tracking this, by the way. Clinical resources, you can find the guidelines at the GI guys. I'm not going to read all that. Society for Gastroenterology, Hepatology, and Nutrition. They do have practice guidelines for our common pediatric GI problems. And that's where you can go to get that. Okay, so why don't we take like a 10-minute break, get a good stretch, get the blood moving again, and we got a little bit more to do.